another. Because again, guys,
lifeblood of a health system. And blood is really, I think, to speak to the theme of today's event, it's an essential component of pandemic preparedness. We know that blood is required for a wide variety of conditions, from trauma to sickle cell anemia, GI bleeding, maternal deaths. But even more interestingly, right, blood is an essential component of the treatment for a wide range of treatment modalities and clinical specialties, whether it's surgery or nephrology and you're putting a patient on dialysis, or you're treating cancer, or it's a child and you're a pediatrician, or of course hematologic issues. You need blood, and without blood you cannot deliver adequate care, which makes this even more sad that there's 102 million unit shortage in LMICs across the world. And every single country in Sub-Saharan Africa and South Asia and Oceania, for that matter, is in deficit. Now, there are a variety of reasons for why there are massive blood shortages. And I think that we, many of the excellent panelists are, Caroline, you've assembled the perfect group of people to sort of talk about this, because this is a longitudinal issue across the entire continuum of blood transfusion, right? There are issues with availability, there are issues with processing, there are issues with delivery of blood. And if we go through the literature, we will quickly find a massive list of all the different problems which we face specifically in low and middle income countries to deal with this issue. But we're here to talk about solutions, and the solutions are achievable, right? That's what is so interesting about this problem, is that there's no rocket science involved. There's no cure for cancer involved. These are all things that we know how to do. We need to mobilize donors. We need to arrange for complex logistics. We need good information systems. We need financing. We need to remove regulatory barriers, and then we need teamwork, right? We need to all work together to make this whole thing work. And it's difficult, but it's achievable. But I wanted to talk about one other thing, which is that worse than scarcity is no blood. And Ernestina's problem, right, was not that she came to a hospital and they said, we only have 2 units of blood when you really need 4. She came to 2 different health facilities, which had no access to blood transfusion when she needed it. And I think this is emblematic of a larger problem, which is that we have what we like to call blood deserts. These are places where there's no shortage of blood. There's just no blood. And these are all over the world. Okay, these are hours to days away from other health facilities that are stocked of blood. And often these other health facilities, they have the shortage, right? So even getting to the next health facility may or may not help you, as was the case with Ernestina. Now, as Caroline alluded to, there are a variety of issues that we can, or potential solutions that I think that already exist, that just need to be implemented, that can alleviate the crisis in our world's blood deserts today or tomorrow, right? That we don't have to wait 5 or 10 years for these changes, so that we can save the next Ernestina. Just briefly, this is the concept of a walking blood bank: emergency blood transfusion, on-demand whole blood transfusion with point of care testing in whatever capacity that is, whether that's ELISA or nucleic acid, or rapid diagnostic testing when nothing else exists. Auto transfusion, a time-tested technique where surgeons will retrieve blood from a body cavity and retransfuse it back to a patient. They're now built-for-purpose devices that many companies are coming up with, and a bunch of innovators all over the world who are working on this problem, but a very high potential to alleviate some of the blood issues that we're having. And then finally, drones are getting a lot of attention, and of course, Rwanda and Ghana implemented variations of this technology. There are several companies in India that are doing the same thing in some of the harder to reach mountainous states of India. Lots of potential, and lots of potential for the costs associated with this to come down. But I want to close by just saying, you know, I think we have two separate but related problems. And I'd really love for us to kind of think about this as two separate but related problems. There's the issue of persistent blood shortages, and there's the issue of there's just no blood. And we have to deal with these slightly differently in terms of the solutions that we kind of put out there and what we aim to achieve. Because if we keep doing the same thing we've been doing for the last 10, 15, 20 years, we're gonna find ourselves in the same position, I think, another decade from now. Caroline, thank you so much. Thank you, CoBA. Thank you for the opportunity, and very excited to interface with the rest of the panel and this wonderful audience. Thank you.
Thank you so much, Dr. Nakul. Thank you for keeping time. I was just about to signal you and tell you your 10 minutes are over. Thank you for bringing the insights. I think a lot of us would never really think about that story of Ernestina unless you do encounter that. And yet for the healthcare workers and the families that get affected by this, it's a very sad story. It's an everyday story. And I think today, as you rightly put it, we are going to discuss the problem. But since we are talking about blood, I want to introduce our very esteemed panel. But before I do that, I have about 56 people who've logged onto this session. And I just want to ask, you know, how many of you have ever donated blood? So there's a poll question that's going to be shown on the screen. And I just want to have a feel from, you know, have you ever contributed to a blood donation at any point in your life? And this is actually giving blood, not giving money to buy the refreshments. And I wish this was an interactive session because I would have loved to ask you why you made your first donation. I want to make a confession. I made my first donation because they came to collect blood from my high school, and there was bread and a soft drink. And I was a very hungry girl in high school. So I went to give blood because I could get to eat some bread. So I want to request our participants to please just you know, have a go at answering that question. There is no pressure, and nobody's gonna take you to court for whatever answer, but it's just to bring you back to the point that blood sits in a, you know, blood sits in our bodies. And we cannot manufacture artificial blood as the current technology that exists in the world. So to get this blood we are talking about, it needs to come from one human being through a process into another human being. So we will revisit the results we get from that poll. Please make an effort to actually vote. It makes it fun also for you to be part of the session. But in the meantime, allow me to now introduce our session, and we're gonna do it first very briefly through a little video, and then I will allow each of our panelists to actually do a very brief introduction, nothing more than 3 minutes, as to who they are, which organization they represent, and maybe just a 1 or 2 liners. Before now we come into the actual discussion, so I'll be posing some not difficult questions, just easy questions to our panelists with the hope that they can enlighten all of us on the issues of blood. So I think we can take out the poll question for now. Let me just answer that I've donated 1 to 5 times, I believe. Oh, apparently I can't vote, so that one goes out for me. So now I move on straight away to introducing our panelists, and let's have the video play. So thank you so much for that brief flash of our panelists. And I want to check whether Dr. Mohammed is with us at the moment. Dr. Mohammed, are you with us at the moment? So he will be joining us back. He had requested that he might have to attend to a certain brief very briefly.
I'm here. I'm here with
you. You are here, sir. Dr. Mohammed, I request that you introduce yourself to our audience on who you are, the organization that you represent, and maybe, you know, what you do. Just about 3 to 4 minutes, and then I will step to the next panelist.
Okay, and thank you, Caroline. My name is Mohammed Abdulaziz. I head the Division of Disease Control and Prevention at the Africa CDC here at our headquarters in Addis Ababa, Ethiopia. In the Division of Disease Control and Prevention, we are saddled with, quite frankly, taking care of the high burden diseases that are responsible for really killing Africans. That's we're talking about the HIV, TB, malaria, and hepatitis and neglected tropical diseases. On one hand, that's one of the units. Then the second unit is the non-communicable diseases, injuries, and mental health. And the final unit is maternal and child healthcare. That's reproductive health unit. And also we were responsible for taking care of the community health system and supporting our member state with community health system. Before I joined Africa CDC, I'm a clinician, I'm a medical doctor who specialized in neuropsychiatry. Then I went into public health. And it was when one of my forays in public health that I saw the advert for setting up the Continental Apex Public Health Institution for Africa. And I applied, and today I was one of the foundation epidemiologists for Africa CDC. And today I'm here as the head of division of the disease control and prevention. I'm very happy to be here to talk about blood and blood products and how we can work together, everyone, to ensure that nobody who requires blood is not able to get it, because it's all about saving life. And if we can make it available to everyone, I think is the best way to go in ensuring that we prepare for the next pandemic, not just the next pandemic, even for the next outbreak. Thank you, and over to you, Caroline.
Wow, Dr. Mohammed, I'm so glad you have, really talked about all the areas you're responsible for. And I think I like that blood underpins all those areas you've mentioned, whether it's the NTDs, the NCDs, whether it's the maternal and child health, the infectious diseases, the pandemic preparedness. So looking forward to putting some questions to you. And you are the third doctor we have on the panel. So we have Dr. Nakul, we have Dr. Nathan, and we have yourself. But please, doctors, be kind to us. We don't always understand the very complex language, so keep the language a bit basic for the rest of us. Otherwise, we'll be writing in the chat questions asking what hemorrhagic shock is. So the next person that we'll be introducing is Dr. Nathan Mulure. Dr. Nathan Mulure, who is the head of government affairs and public policy for Terumo BCT, Sub-Saharan Africa. Over to you, Dr. Nathan, kindly.
Thank you very much, Caroline. Great pleasure to be here in this congregation. And I'm very thrilled that I'm part of this panel. So Nathan Mulure is a medical doctor by profession, having worked in the pharmaceutical industry for about 20 years now. I was in the access to medicines arena for a long time, and I had never thought about access to blood. Shame on me. I never thought about access to blood. And having joined Terumo, actually, I now realize how important blood is, and how blood is fundamental to the healthcare system. Basically, without blood, you can't do much. Even giving that patient tablets or injections, without blood, there's no volume of distribution actually. So there'll be no action on that product. So I'm really happy to be in this space of discussing blood, and really to push the agenda for access to safe, adequate blood in Africa. Very thrilled that CDC is getting to the heart of this. This is quite impressive. CDC has done a lot of work. We've seen your leadership. Now we want to see this leadership also in blood. And I'm sure that if this happens, then blood will become adequate to all Africans. We all have blood. We're working with blood, but the dilemma is that people who need the blood don't have it. How then can we get people who have the blood, who have adequate HBs, how can we get them to donate that blood so that the people who need the blood can actually have it? Yes, so about myself, I've worked with the pharmaceutical industry for 20 years, chasing access to medicines, a degree in public health, Master of Science in Pharmaceutical Medicine, and also I love prevention. So I did a degree also in cardiovascular prevention medicine. And I hope that with these tools, we'll be able to make sure that public health becomes top on the agenda in Africa, and also to prevent diseases. So I work for Terumo, just joined the other day. I'm now 4 weeks old in Terumo, and I'm terrific about blood, having joined Terumo. Terumo is a company that is founded in Japan about 100 years ago. And it has 3 divisions. The one that I'm working for now is Terumo BCT, headquartered in Lakewood, Colorado, USA. And from this, we manage about 130 countries with about 7,000 associates. In Africa, we are based out of Nairobi. That is our headquarters, managing Central Africa, basically the whole of Africa below Sub-Saharan Africa and above South Africa. That's our territory. And so glad to be here, and yeah, looking forward to great discussions. Thank you.
Thank you so much, Dr. Nathan, spoken like a doctor. And I always like the way you're so passionate about blood, and I'm so excited that you're part of this panel. And I'll be coming to you with some questions. Now I want to go to a lady in the room, and that is Erica Monfadini, who is the Director of Global Pharma and Strategic Partnerships in B Medical Systems. Erica, you may introduce yourself.
Thanks a lot. I'm really honored to be part of this panel with all these eminent speakers. So I'm from B Medical Systems. So B Medical Systems is a company that is in cold chain, so medical refrigeration, and which has been and also in blood management. So I would say systems for storing and stocking and transporting and vaccines and blood throughout the world. So we have been working in Africa across the continent for more than 40 years in partnerships with Gavi, with PATH, with WHO, with all the actors that are present in Africa for really improving the I would say the access to medicine, and we are extremely proud to be part of this big picture and extremely committed to deliver our products, but most of all, I would say the medicine and drugs that we carry, so blood included to the patient. So our characteristic is that we have a lot of local knowledge. So we have employees that are extremely knowledgeable, extremely resilient on the ground, that distribute the drugs, the blood and the vaccines to the people, that do the mission impossible of reaching the most remote community. So when I heard about the Ernestina story, my heart was really sad, because despite all the efforts that we do together with other players in the market, competitors, industry players, we actually did not manage to achieve our goal. So I would say our company is really committed to really deliver the care to the people, and we put a lot of effort, I would say, in the local knowledge, in training the people, in the innovation, and into the R&D also for really developing innovative solutions. So that is B Medical Systems. And me, as far as I'm concerned, yes, I started with research. So I have my PhD in physiology and immunology, and then I moved into the pharma industry. And I've been working in the pharma industry for 10 years, then in consulting, and then in management. So I've actually done several moves in my career, but my values were really very deep into doing and contributing to the world. So I decided to quit a position and to join B Medical Systems for the values of this company, because I believe that this company is really acts towards the low middle income countries. Most of our business is there. And really, I think that we, in our little, actions, we want to contribute to the well-being of the in low middle income countries, and also especially in Africa. That's all for me.
Wow. You never told us that before. I didn't know you gave up a very lucrative position to come into a company that would allow you to actually have impact Thank you for making that decision, and looking forward to hearing about the 40 and plus years of experience that B Medical has had on the continent. I think for Africa CDC and the rest of us here will benefit from knowing how you are able to serve the continent so well, despite the difficulties logistically that typically most people experience, how you're able to partner on the continent and be able to make sure that most of us sitting here on this call today could get vaccines even in the most remote place. So I think looking forward to learning from that. I just have two more panelists to introduce, and luckily these are now young people, so I expect them to move faster. I'll go for the gentleman first, Mr. Aaron Ogunde, who is the co-founder of Damusosa System Limited, based out of Kenya. Aaron, over to you.
Thank you very much, Caroline, and hopefully my introduction can match those who've already gone before me. My name is Aaron Ogunde. I'm the co-founder, the CEO of Damusasa. At Damusasa, we are a digital healthcare solutions provider, primarily working to facilitate timely access to safe blood products for patients. We do this by providing digital platforms that help blood banks to easily share blood products in real time, thereby shortening the lead times for patients who need transfusions. Essentially, we want to help build a big blood bank for Africa by enabling all the existing ones to collaborate in real time, including the ones that are walking around, as earlier mentioned by Dr. Nakul. About me as an individual, my background is in software engineering. Recently now running a startup in the healthcare space. Recently also published author, and I'm happy to be here because I think in my own little way, I'm also an avid champion for blood services improvement in Africa. So this is actually an exciting time for me and a privilege to be in the midst of such qualified speakers on the panel. So thank you very much, Caroline.
Thank you, Aaron. I'm equally intimidated. I am wondering how I'll get to put questions to this esteemed panel because people are so well schooled and have vast experience, but we're gonna do our best. So thank you, Aaron. And I left the best for last. I have this very beautiful young lady who is Bukola Bolarinwa from Nigeria, and she's the founder of Haima Health, but I celebrate her more because she's a lovely lady that's living with sickle cell disease and has battled this disease and is sitting here with us today to give a testimony of what it means. So for now, just do an introduction for me, Bukola. I'll come to give you a platform to now speak about your experience and the lovely work you're doing in blood donation. I applaud you for that. Over to you.
Thanks so much, Caroline. Hi, everyone. My name is Bukola Bolarinwa. I'm from Nigeria. I have sickle cell disease, and I run an organization called Haima Health Initiative. Haima focuses on mobilizing young people to donate blood. We also have an online register for voluntary blood donors across Nigeria, and we carry out monthly blood drives across 6 states. So we really work in the community advocacy space, trying to improve the supply of blood for blood banks in Nigeria. We also do a bit of work on logistics as well around blood, which I'll get into a bit. In my day job, I actually work as a lawyer, but I'm really passionate about health systems improvements generally, and my personal experience living with sickle cell and the challenges of getting blood for the sickle cell community. So it's really a pleasure to be here amongst such an amazing panel. Thank you.
Wow, thank you, Bukola. Something about the youth. They tend to move faster through the instructions than people like myself. Thank you so much, Bukola and Aaron. And I think now, if you would allow me, I want to now come into the actual panel discussion. And before that, I just wanted to give you the results of the poll that we ran earlier. So we asked whether you have ever donated blood, and about 32% of you have donated over 5 times. Congratulations, that's really super. About 24% of you have donated 1 to 5 times. Then there is a good 12% that's only donated once. So I'm not sure why they've not gone back to donate again. And then there's a very nice worrying percent of 32% who have never donated. And I would just have loved to see in the chat the reasons why you have never donated, or if you've ever donated once, why you haven't gone back again. Is it because we've not given you a soda? What's the reason? So let's try and put our reasons in the chat. I would really love to hear from the people, because for those of you who work in donor recruitment, Aaron, you understand that, and Bukola, you understand that. We like to understand why people are not making the donation. Are you challenged in weight like Caroline here, who is rarely over 50 kilos, in which case she needs to eat more, starch or something? Are you challenged in HB? Again, that is Caroline, who is at 11.5, and I'm not eligible. Are you not donating because you're not aware that we need blood? We want to know the reasons so that now we can see how best to make sure that Africa has sufficient blood. So now I would like to come straight into now the panel discussion. And Dr. Nakula, I'm very glad you're staying with us, because we might pose a question or two to you. So if you don't have to go for your surgeries, you can stay with us for the 2 hours. And I want to start with Dr. Mohammed. Dr. Mohammed, if maybe we could just have you on camera. Dr. Mohammed, I think just thinking about the problem of blood in Africa, lower middle income, but let's specifically go for Africa because of your experience. What do you think is the role of the continental health policy bodies like the Africa CDC, like the AU, like the WHO, AFRO, in ensuring that the member countries are prioritizing blood? Because we look at it and we say countries are dealing with so many other issues that may come across as a priority. How can the Africa CDC and the other policy bodies make sure that countries are prioritizing blood? And I'm thinking about the docket that you hold. You can just help us see, what are you doing now, or what could you be doing to make sure that blood is prioritized within the country priorities?
Yeah, really, thank you, Caroline. Are we having echo? Oh, good. So transfusions of blood and blood products save lives. Everybody knows that one. And we all know that even just a single unit of donated blood can save up to 3 lives. And blood transfusion can help all wide range of patients. Even if you take my division, in all the units that we work with, every single one has an interface with blood and blood products. And in international bodies, health bodies like WHO, other WHO Afro headquarters, Africa CDC. We know Africa CDC, but again, I want to lay emphasis. There are some continental bodies also coming up, like the African Medicine Agency and the Africa Continental Free Trade Area, all important in ensuring that we have safe blood products available for people when they are needed. So let me first talk about what are the things institutions like WHO can do to improve, to support our member states in making blood and blood products available when they are needed. So it's important that WHO and the rest are able to in the areas that are cross-cutting, support member states in developing standards, guidelines, tools that will support the setting up of blood transfusion services in the member state. So let's look at the first one, maybe development of standards, policies, and frameworks. For example, when we talk about a standard on self-sufficiencies and guides to member states to achieve self-sufficiency in blood and blood products. But what are we talking about here? We know that some countries have done much better than other countries. So WHO is working across several member states. They can harness lessons learned, best practices, and put them in an easily reached document that can be used to support all member states. Because one of the things we have learned about the COVID-19 pandemic that taught us is that we are only as strong as our weakest link. So we need to support even countries that do not have that ability, that have not reached where we want them to reach, by looking at lessons learned from other countries that have gotten it right, put it together, and allow them to also learn from that, develop frameworks for blood safety and availability, which will also really help countries to leapfrog and get to the highest level of evidence in the in that kind of space. We also, it's important to help in the development of tools to guide national and regional efforts to ensure access to safe and adequate blood supply in emergency situations and other and during pandemics and outbreaks. Let me give you an example. During the COVID-19 lockdown, many women who require blood transfusion because of childbirth could not get it, because to get to the hospital was a problem. And when they get to the hospital, people who will go to donate were not allowed because of the lockdown. So we need to have well laid down rules and regulation that talks about humanitarian corridors that allow people to be able to go and donate blood, even during the times of lockdown, during times of emergency, during times of outbreaks. We need to, and this kind of environment can only I mean, we WHO, Africa CDC can help set up this kind of procedure that allow people who need to donate blood to go voluntarily, even when there is lockdown, when there is curfew, when there's any sort of this thing, to be able to get to the patient that requires blood. Also, setting up quality systems and hemovigilance is very important. We need to support our member states in establishing external quality assessment programs for screening donated blood for transfusion transmissible infections. We learned, for instance, if we do not do that, then even the safety of the products we are giving the patients is called into questions. And we need to let people have confidence that when they are being given blood, it is safe and quality blood that has been tested and is free of any form of infection, and we can be able to follow some of the effects that may come after them. We need to support member states for national blood regulatory systems, support in the good manufacturing practices, support blood and blood components to be added to essential medicine lists. This is very important. We need to support our member states in getting to that space where blood and blood products are added to the essential medicine list. It's not by a choice. It's something we need to do. And of course, update existing legislation for blood system using the best available evidence. We shouldn't be using legislation that is 50 years old. We should be able to update it, support member states to update it using the best available evidence. We should also work towards ensuring universal access to effective and quality blood products. It's not acceptable that a woman in one maybe in Madobi local government area of Kano State in Nigeria, far away from the Kano Municipal Council, does not have access to blood products when it's needed, whether for the treatment of the side effects of maybe complication of cancer, or even during childbirth, or even because a child requires a blood transfusion due to sickle cell anemia, which is life-saving. All of these, one of the things we need to do is to ensure that we put these within the space of our principals, especially policymakers, to set up processes that will allow these products to get to people no matter where they are, and not just a privileged few that live in the urban centers. And then, of course, support evidence generation to improve service delivery. For Africa CDC, because of course we are not as old as WHO, but what we can do is to look at all of this and see how we can contextualize it to the African context, because we know the context in Africa is a bit different from the context in North America or in Europe. So we need to contextualize it in such a way that the unique things we have on the continent will be taken into consideration to ensure that these blood and blood products are taken, the efficiency with which we handle them is well connected. Finally, we also we should take advantage of institutions that are coming on board. The African Medicine Agency is an institution that African Union is setting up to reduce the bottlenecks of regulation. Regulation is good, but it should not be a bureaucratic process, because when we talk about blood, we're talking about emergency process and how to streamline it to ensure that we can get blood to the person who needs it in a safe and very quick way is what I think when the institution like African Medicine Agency gets operational will be on top on their priority. Thank you, Caroline. I hope I didn't take much of the time, but let me hand over back to you, and I can talk later about.
Dr. Mohammed, you're our boss, Africa CDC, so we will give you all the time you need. So I had no problem. You went a little bit over, but I think what you have shared is so powerful, and it's made me change the way I was going to ask my questions. So I want to put a question to Aaron. Aaron, if you're there, I remember listening to you talk about Damusasa once, and during the COVID-19 period. Aaron, I hope you're there. Maybe we could see you on camera. And you mentioned something very specific, that Damusasa is pandemic friendly. And I've liked what Dr. Mohammed has spoken about, that we need to make sure that even when we are having the pandemics, that we can still collect the blood that we need to save lives. Because you don't choose when a baby will come. You don't choose when a sickle cell patient will need a transfusion. You don't choose when a traumatic accident will happen. Tell us a little bit about the innovation of Damusasa and why you say you're pandemic friendly.
Thank you very much, Caroline. I think it's public knowledge that during the pandemic, blood was one of the areas that was worst affected when we're talking about healthcare. And, that is because the number of blood drives reduced due to social gathering restrictions. Then that led to extremely low levels of blood collection. And unfortunately, as reported in Kenyan media, some patients lost their lives. And in meeting this challenge to ensure that blood donations kept going even despite the pandemic, Damusasa, collaborating of course with blood donation centers, we developed a blood donation appointment booking feature, and this works similarly to a bus or a plane ticket booking system, where each hour only a few individuals could book to donate based on the donation center's room and capacity to prevent overcrowding. We also added a mini feature to allow blood donors to share their experiences while donating. And this, was like feedback that was useful to the blood donation centers and which helped them to really improve because COVID was something we were all dealing with for the first time. So all these things summed up together helped to keep blood donations going during the pandemic, where I can actually book for a blood appointment donation slot, where I am sure that within that slot, I will not find crowds gathering. And so I can, protect myself from COVID and at the same time be able to do my part in helping to save lives by donating blood. So I guess when we say Damusasa is pandemic friendly, that was one of the ways that we help to keep blood donation ongoing. Of course, there are other ways in which we used to keep patients or to facilitate patients' timely access to safe blood products, which was integrating the different hospital blood banks through one platform, thereby allowing them to easily share blood products. And that actually shortened the lead time for patients who needed blood for transfusion. So I guess that's in a nutshell what we mean when we say Damusasa is pandemic friendly. Caroline, I hope that answers the question.
I think so, because I was just very keen to get your thoughts on that, because I remember distinctly having conversations with yourself and you really talking about it and talking about the great work that you were able to do in Kenya. And I'm happy to learn that now you're spreading out to Tanzania and other parts of the continent, and I hope we can all benefit from this technology. Maybe for those who may not know, Damusasa was actually founded by two very young Kenyans. It is Aaron and his colleague called Francis, who are alumni of a presidential digital talent program. And it's very exciting to see the youth starting to provide solutions. And I think, Dr. Mohammed, when Africa CDC is looking for great minds to contribute to the continent, you want to look to some of these minds, because I think they're really great, and what they are providing are great solutions that will help us. But just crossing over to something that Dr. Mohammed again mentioned, and I'm going to again change my flow a little bit. Dr. Nathan, you and I have had several discussions about essential medicine list. And I know a lot of us who are on this call may not be clinicians. So when Dr. Mohammed says blood should be added on the essential medicine list, what does that mean to the layperson? Like, what does that mean when Bukola is sitting there in Nigeria and trying to rally blood for sicklers? How important is it for her that blood is on the essential medicine list for that particular country? And here we are speaking for the continent. Just help us understand that concept a little bit more.
Yeah, thank you very much. And it was great to hear the previous speakers making great contributions. Yeah, actually, blood actually is on the essential medical lists of WHO since 1977. You can imagine that long. WHO had passed a framework allowing blood to be on the EML list in 1977. What does that mean for countries? It simply means that countries have to take that cue and ensure that blood is available and accessible to everyone who needs it. That is the essence of being on the essential medical list. The government is empowered to ensure that this blood is available for everyone who needs this blood at an appropriate time, appropriate dosage, without too much struggle. And also that gives the government the mandate to invest in infrastructure and ensure that all the infrastructure is in place to ensure that this happens. It gives the government also power and power to legislate and put laws in place to ensure that blood is available. So it's a very, very powerful attribute to have a product on the essential medicines list. It's unfortunate that in Africa we are quite late in terms of matters of blood. We are 40 years, 50 years late, but there's legislation already in place globally from WHO, which can guide countries in putting this practice in place. Blood, of course, is a big challenge of blood in Africa, and we all know why. There's been little investment on blood and blood matters in Africa for the longest time. Personally, as a person who has worked for the industry for 20 years, with all my knowledge, I did not take blood that seriously. You know, I didn't even imagine it's in the EML list. I didn't dig a lot deeper. And I'm not the only one. And there are very many people who also are very ignorant about blood and blood matters. How can we then change that culture to ensure that we as Africans are able to also to donate blood and ensure that blood is available on a continuous basis in these countries that we serve? Yeah.
And Dr. Nathan, I wanted to continue with that thought. You know, I was reading the WHO report that was published in 2022. And they say 35 out of 48 African countries are collecting less than what WHO recommends, which is 1% of our population. So for every 1,000 people, we want 10 units of blood. We are collecting less than 4.6, around 4.6.
Yeah.
And just from your own thoughts with your experience, and I know you've said you've come into the blood space late, but you and I are together. I also just came into the blood space 6 years ago, so I'm very embarrassed to admit that. What can we do to increase the blood supply? You know, what can we actually do? You've listened to our audience and you've seen how many people are donating, and 32 have never donated, for example. What are some of the things that you think we could do to increase the blood supply on our continent? And thinking just in a very basic way, and even now going to the higher level.
Yeah, that's a great question. How do we increase blood supply in our systems? Like I said before, there's a lot of blood in Africa. We are 1.2 billion people. And most of these people are actually healthy and can donate, but they're not doing it. There are various reasons for not donating blood, including ignorance. And it's a whole continuum of supply chain. It's not just a one point, solution. It's a whole continuum. And what we find in most African countries is that there is lack of infrastructure in the government facilities, in the national blood transfusion services. Are they able to even receive that blood? So you might go out there and make a lot of noise about donors coming to donate blood, and there's an upsurge of donors coming. And then you find that the system can actually not handle that amount of blood. And what is so distressing to a donor is to be told that, yes, you gave blood, but your blood was not used. Why? We didn't have space to store. And that happens in emergencies. Sometimes when there's a bomb blast or there's a terrorist attack, you find tons of people coming and then they give blood, and you start reading in the newspapers, oh, your blood was destroyed, your blood was, thrown away, and you really get discouraged to give future blood. So that infrastructure has to be in place before you even make this noise about blood donors coming into place. Then secondly, once we have that infrastructure, now we need to go out to the donors and entice them to start coming to donate blood. In Africa, unfortunately, most of our blood is not from voluntary, non-remunerated people. It's not from voluntary donors. It's actually people who solicit donors from funding, from families, from friends. It's a closed knit society that then donates blood to this particular patient for him to recover. We need to encourage a culture of voluntary blood donation service, which can be done every four months per patient. So you have a register, and I like what Damsosa is doing. That register is lacking in many African countries. There's no registration. So a donor comes ad hoc, donates blood, and disappears. We don't even capture their details. So can we have this register in place so that donors, there's a pool of donors who are actively donating blood every 4 months, and some who can be called upon through SMS or through text message that, hey, there's a patient who needs your kind of blood, please come and donate this blood. So that registration and digitalization is very, very important in terms of that infrastructure of donors database to be able to be called upon at any time. Then thirdly, avoiding wastage. Sometimes we donate blood and it's wasted because of various reasons. Sometimes there's a lot of maybe there's donor screening wasn't done in good place. Donor screening was faulty, so the blood that was collected was not even important or safe, so it's discarded. I read somewhere that globally about 13 million liters of blood is discarded because of wastage. 13 million, it's a lot. So how can we reduce wastage? One way, of course, is to have the voluntary donor pool that are considered less or more safe than the ones that are solicited by family members to donate blood. So avoiding wastage and investing in technology. There are now machines in place which can help harvest blood in a very efficient manner and even automate this process to maximize on what is collected. Yeah, so that's what I would put in, across as ways of us to, get blood supply to be adequate in our medical systems. Thank you.
So it's good to hear from doctors. I think I've learned more from doctors in the last 5-6 years than everything else I knew. So nowadays, I call myself Dr. Caroline with a small letter D, not the big one, like everyone else that's here. I think just listening to the conversations, Erica, it made me think, listening to the history of biomedical systems, you have been working on this continent for the last 40 years. You have been delivering vaccines. Vaccines are so powerful in saving lives. Most of us born in the rural parts of Africa would have died if vaccines would not have gotten to us. And even 40 years ago, 50 years ago, when we were being born, you were able to work on this continent and to deliver vaccines to us. So I'm listening to the story of blood. We are talking about a donor. We saw Dr. Nakul speak about the story of Ernestina, and I had to wonder about the logistics of the blood getting to her. I want you to help us understand, blood is only available to save my life when it actually reaches me in the right condition, when it's been tested. And B Medical has had great experience on the continent moving vaccines, and now you're involved in the blood ecosystem also. Help us understand what lessons we could learn from your experience in just making sure that the blood that is supposed to save a life is able to reach that person? What can we learn from what you are able to do so successfully and are still doing? Because that seems to be the missing link in some way, where we are having a lot of blood in one place, but there's a place where there is scarcity, or as Dr. Nakul said, we actually have a desert, there is just absolutely no blood. What experience could you share from what B Medical has been able to achieve to help us in the blood system? And I know Dr. Mohammed will simply be taking notes as you say this so that he can just work straight away to implement whatever good insights you'll be able to give. Let's hear from you, Erica.
So first of all, I'm honored. I am humbled to be asked this question. I think that our success is the success of the collaboration of many people, actually. So if I could share my humble, our humble experience, or B Medical's humble experience, the first element of success in which, so yeah, we have distributed vaccines, but we are also, I would say, knowledgeable in terms of blood. So I would say the first element of success in such a complex matter is called people. So I would say that it is extremely important to invest in people, meaning investing into the attraction of the talents and into the training of the healthcare professional to be able to somehow develop a retention mechanism. And also, I would say, not only within the blood banks that we have and that we are developing, but also within the hospitals Dr. Nakul was speaking about. That is extremely, extremely important. Also, to invest into awareness mechanism, so that I would say people in the continent know about the importance of blood, and this is why the creation of the CoBA is so crucial. I'm really confident that this kind of webinars, events, and your power of reach is gonna increase the awareness. That is another element that we have developed in for example in vaccines. Without the help of UNICEF, of Gavi, of the CDC, we would be nowhere. The whole continent would be nowhere. So I would say that is the fact that the people know the difficulty, people have a vision, people know where what has to be done, and everybody brings his little contribution. Another investment that has been extremely important to us, both in vaccines but also in blood, and that has to be fostered forward, is the processes. So the processes have to be described. The I would say the collection, transport, the transportation, the separation of the blood, the fact that it has to be after separation, frozen, stored, and then transported again, and then towed, and then fractionated, and then reinjected into the market is extremely, extremely complex. And the process has to be described in a very simple manner, has to be embedded into the mind of the healthcare professional in every little detail. And also those people need to know when there is an issue to spot it and to bring it up, at a higher level, or if they are able to solve it. So every little drop of blood or plasma is very important. And so when you have the awareness, when you have the people who know what to do, and the process described already, say the critical mass of the blood would improve. Then there is something else for me that has to be done as a step forward, is the investment into the machines for separating the blood, for freezing it, for stocking, for towing, but also for fractionating. So fractionation would allow the blood the plasma to be thrown away and to be used for saving lives. There are medicines that are essential that can be actually produced from the plasma. And I would say the fractionation requires machines, requires knowledge. Sadly, in Africa, we only have these capabilities in Namibia, Rwanda, South Africa, and I think that this is definitely not enough, and some solutions have to be found. I would say the last lesson we learned that one of the few last lessons that we have is the power indeed of, I would say, the infrastructures, how even if you have little infrastructure on the field, how it is organized. There must be always a national hub, and some even spread, I would say, regional hubs, that actually the regional hubs are in charge of the collection of the blood, separation, and then, or I would say stabilization of the blood so that actually can be transported into the national hub for the treatment. There are also innovative solutions, and, the one that Mr. Ogunde has developed is immense, is just amazing, and that is one of the ones that I would like to really bring forward. So this kind of apps and this youth that is putting energy into changing the world is really amazing, and that brings a lot of hope for Africa. There are also point of care solutions that allow testing on the spot, and that is really important. But there are also solutions such as the solar powered blood banks that actually allow to store and stock the blood into in a safe, even with power cuts. And then also transportation solutions that are very flexible, that allow to transport bags at different temperatures, even to be plugged into the cars. So I think this is the whole.
Wow, you could write a book about all that, Erica, and I'm sure I'll be coming back to one or two of those points. I like what you talked about the plasma, and we've just come from the CoBA team was speaking at the International Society for Blood Transfusion in Cape Town, and we had an opportunity to have very good meetings with the fractionators in South Africa. That's the National Byproducts Institute. And they will be joining CoBA actually. And one of the discussions they're looking at is how to take the excess plasma that is available in the other African countries and export it to South Africa, because setting up a fractionating facility is expensive and not every country might be able to do it. But they want to find a way to leverage a partnership there and be able to take the plasma and process it, and now bring us the plasma medicinal products that are so critical for the hemophiliacs and the other conditions. So I just love that you brought that up, because this is a discussion we were having 2 or 3 days ago, and we're going to be following up with calls on that. Now, I know there's a lady that's feeling neglected on this call, but I was keeping the best for last. And Bukola, before I ask you a question, I want our pollsters to give us just one little question about sickle cell disease. And I want to see how much fact or non-fact that most of us know. So the question is, to sustain the life of a sickle cell patient for a year, how many donations are needed? So I want you to think in terms of actual pints of blood to sustain the life of somebody with sickle cell disease. And this question is just supposed to allow us, the audience and the panelists, to appreciate that there are people with conditions who require blood very regularly. And sometimes when we talk about blood, we forget that these wonderful people exist within our community, and we need to also think about them. So I hope you can answer that question. Is it 52 pints of blood in a year? That's like once a week? Is it 100? Is it 130? Is it 150? And I think I will be coming back to that very, very soon. But Bukola, I think this is your moment. And I was very deliberate in having you on this panel, because sometimes when you put experts in a room, these wonderful people, the doctors and the policymakers, sometimes they speak to a problem as if it is very far away. And it's important in life to put a face to a problem. And I'm not saying you are a problem, that is not what I mean, but you are a lady who has battled sickle cell disease your entire life to your young adult years where you are right now. And from my understanding, I'm not a doctor, is that I know people with sickle cell disease require urgent blood transfusions, and some will require them so many times in a year. We're going to get to the answer a little bit later. Just give us a little bit of what it is like to live with this blood disorder and how that connects to your need for transfusion and how that need has been met or not met for yourself maybe, but also speak for the entire fraternity of warriors, even some who maybe left us because that blood was not available when it was required. And I wanted you here so that Dr. Mohammed can hear from somebody that lives with this problem. I wanted you here so that all these private sector players that have solutions can be able to answer you today. Today, you become the face of everyone with a blood disorder on this continent. And all your answers from now will be directed to Bukola because she becomes the face of what we are fighting for. So Bukola, talk to us a little bit about your journey with sickle cell disease and your experience this far in some of the people that you know.
Thank you, Caroline. So I don't want to assume that everybody on the call knows what sickle cell disease is. So I'll just give a brief overview. Sickle cell disease is an inherited blood condition where you inherit 2 faulty genes from each parent. And what that means is that instead of your red blood cells being browned like a normal person, they're sickled shape or look like a banana. And that basically means that blood isn't able to flow as smoothly across your body, and that causes blockages in different parts of your body. Those blockages cause a lot of complications, the most common of which is pain, which is why a lot of people living with sickle cell have something called a sickle cell crisis. So sickle cell crisis is essentially just pain, which can happen in any part of the body. And over time, this can also lead to things like organ damage. It can affect different parts of your joints and so on, which can also create situations where you might need surgery. But more on a day-to-day basis, the sickle cell crisis manifests as pain, really intense pain that usually needs hospital admissions. One of the treatments for sickle cell crisis is blood transfusion, and that essentially means that they are giving you new, fresh blood to basically support your kind of system with your red blood cells that are dying much quicker. For a lot of people in like the Western world, you're able to have something called a red cell exchange. So red cell exchange basically means they take out all the blood in your body and replace it with new donor blood. And for an average person, that can be 7 or 8 pints of blood in your body. This done simultaneously. So as the blood is flowing out, new blood is coming in. And so for a lot of people living with sickle cell, it means that you're receiving blood transfusions several times a year, sometimes 7 to 8 pints. I have several friends who are on repeat exchange transfusions, which means that every 6 to 8 weeks, they go to the hospital to have all their blood taken out and have it replaced by new donor blood. So if you do that calculation, similar to what you said, you can imagine how many pints of blood that someone living with sickle cell who's on chronic transfusions is going through. Living in Nigeria, it's extremely challenging getting people to donate blood. I saw a comment in the chat where someone was asking about the effects of donating blood, and if it's true, whether when you donate blood, you become very sick and weak. And questions like this are very common for us that are out in the field trying to recruit donors. A lot of people have a lot of fears around donating blood. And so what you have in a lot of African countries is family replacements, right? Where if I need blood, what I'm going to do is reach out to my immediate circle, my friends, my family, people that know me, and ask them if they can donate blood. They're more likely to give because they know me and they can feel, a certain type of pressure to help. But generally, if people don't have that interaction with someone living with a health condition like sickle cell disease, or maybe having a pregnant wife, that interest or motivation to donate blood is really, really not there. And it's really difficult to explain to people why it's important to do this. And we can go more deeply into the reasons why people don't, want to give blood, what the different motivations are, what the challenges are. But it's important, like you said, for a lot of people to understand that for people living with chronic conditions like sickle cell, hemophilia, and so on, these are conditions that are not going away. Hopefully, there's new cures coming for sickle cell disease, but in the meantime, sickle cell disease has to be managed, and part of the management is blood transfusions for now. So it means that for us, this isn't like a theoretical thing. This is life or death. This is our daily experience. This is us like having to imagine a lot of people, especially in Nigeria, being in hospital. You're sick, and you're still having to message people on WhatsApp, please, can you come and donate blood for me? Please, can you reach out to someone to come and donate blood for me? And then there's also the costs associated as well with blood, right? Because even if you get someone to come and donate blood for you, the hospital is still going to charge you because they have to screen the blood. They have to go through all these different processes before they make the blood safe. A lot of people cannot afford that. Just last week, we had somebody that reached out to us and was like, oh, I really need this blood transfusion, but it's 30,000 naira they're charging. 30,000 is about, I'd say $15, something like that. And she couldn't afford it because for her, she already had calculated how much her hospital bill was going to be. There's no health insurance. And so she has to pay that money out of pocket. And so people are having to make decisions about whether or not they want a transfusion because of the cost, right? Even when the blood is available. So for people living with sickle cell, the issue of blood is so complex, it's so emotional, and it's really, it can be really exhausting because it almost feels like it's not something that's prioritized by anybody. It seems like there are other more important healthcare issues, but for people living with chronic conditions, this is the most important thing for them.
Wow. Thank you, Bukola. And I just want to give you the results. So it's a very nice video, which we will try and get a link and share with you later on, where somebody presents and says 130 donors saved their life in a year. So for the average person with sickle cell disease, they need 130 donations. And the poll that we did, 23% of you are able to get that correctly. I don't know whether you were guessing or whether you knew it as a fact. I hope it wasn't guesswork. At least I'm lucky because I knew that. But a sickler requires 130 donations. So you can imagine today, we are thinking of blood for the hemorrhaging mother, for the anemic, and that these people that have a chronic condition, an uncommunicable disease, that need blood every other day. And we are not availing that blood. So what Bukola did not tell you is that more than 50-60% of people born with sickle cell disease die before they get to the age of 5 years. And amongst the many things that we lack is sometimes we lack the blood to transfuse them when they need it. My next question would have gone to Dr. Mohammed, but because of something Bukola has said, I want to ask Aaron first before I come to the Africa CDC. Aaron, how do we deal with this issue of awareness? How do we deal with trying to get the donor to get some of these questions answered? Like I have seen Bukola talk about somebody asking if they donate blood, will they get sick? Ladies will be asking, can they donate when they're in their menses? Somebody will not know whether they can donate when they have antibiotic. And I know Damusasa, apart from Damusasa, is a place of innovation. And I just want to know, what is the role of technology and innovation, and even maybe artificial intelligence? You look like the kind of people that could already be embracing artificial intelligence. How can it help us to just demystify these fears that our donors could be having? What is the role of that? And considering that Africa has that demographic profile of having a lot of young people, I think you're well positioned to speak for them and to speak to them in telling us what are some of the things we can do in using innovation and technology to break down the barriers to blood donation. I really would like to hear from you on that.
Thank you very much, Caroline. I think what my colleague, Ms. Bukola, has mentioned, that there are certain issues, or we can call them knowledge gaps, that prevent blood donation activities from happening. And, we get these questions as well. Like she said, I've seen some on the WhatsApp, on the Zoom webinar questions, and some people are even actually asking as we continue this webinar. As Damusasa, how we going about this challenge. One of the things we're doing, of course, which is at the core of what we do, is using technology to meet this challenge. Specifically, when it comes to the knowledge gaps, you're right, we are embracing artificial intelligence, specifically on the areas of education, that's blood donor education, recruitment, and retention. So, for example, we've recently concluded research with the IDRC Canada, Google Africa, and the University of Nairobi. And as I said, the preliminary findings point to a diverse knowledge gap among different population segments that is hindering donation activity. So we have, when I say population, different population segments, we have people who have tertiary education, people who have up to secondary education, people who are employed, people who are not employed. So all those different segments have different knowledge, attitudes, and psychology towards blood donation. So what we have done in rising up to that challenge is embrace the use of AI. And specifically the use of AI is to help such people to adequately prepare for blood donation by having such questions answered. So the challenge really is not that people don't know they should donate blood. The challenge is the barriers in terms of knowledge that would then hinder them from donating. Such questions as, will I become sick when I donate? So they know that they're supposed to donate, but the challenge is, would I become sick? So such questions need to be answered and in real time. So what we've done is, build an AI engine that people can interact with. And that engine actually is deployed over WhatsApp. So it's more like having a personal aid that prepares you for blood donation. And more like speaking to a friend as you normally would on WhatsApp. And I think it will be quite helpful for blood donors to actually interact with the engine and have all questions regarding, how do I prepare for blood donation? What do I do after blood donation? How much water do I need to drink? In case I notice anything unusual in my body, who do I report it to? So the engine is also able to link such people with centers for secondary care. So in our own little way as Damusasa, we're constantly innovating to try and improve the service, to try and spur increased blood donations on the continent. Again, if we can talk about AI the entire session, but just to mention one last thing is that we're also using AI across other segments of the blood transfusion value chain, whether we're looking at blood banking in terms of being able to predict demand patterns so that you can help prevent unforeseen shortages, and even applying now AI to transfusion medicine, where we're able to give suggestions to the clinicians based on a patient's ailments and transfusion history. So what would be the best blood product to use? Have you used too much of whole blood? Now you need to consider something else like cryoprecipitate. But those are just some of the applications that artificial intelligence can have in the blood services ecosystem. And I think it's about time that technology innovation is actually brought into the forefront as part of the solutions provider, or as we continue to search for solutions, given that, as you mentioned earlier, about 38 countries are collecting less than the 1% average required. So I think technology does play a role. And I think we in Damusasa don't just talk about this, we're actually living it on a day-to-day basis and seeing the potential. Thanks.
That's amazing, Aaron. I think you need to put some details. You need to put some details in the chat on whether you've already launched this and how we can access it and how we can start playing around with it. And I hope you've accommodated languages for us, because Africa, we have all the different languages. I hope you've thought about the languages and made sure that if I'm in Tanzania and I'm Swahili speaking, or I'm in Ivory Coast, I hope I should be comfortable language-wise.
Yes, so far we only have 3 languages. That's English, Swahili, and French. So we're trying to work as hard as we can to increase the more languages that are spoken in Africa.
Wow. Thank you so much. And I think, Bukola, we hope by leveraging some of these solutions that we can expand that awareness and close the knowledge gap that can allow more donors to come on board. I would love to see that percent of 32 that I found earlier to move down to about 5%, the people with chronic illnesses or the ones who have to be deferred. But I want to now put my next, yes, sorry.
No, I was going to say it's really interesting to hear Aaron's perspective, because I would say in Nigeria, like we struggle really with a lot of the community don't have the basics. And I see that people in the chat are also saying that it's not so much about the technology, it's more about the fact that the socioeconomic circumstances are really difficult for a huge part of the population. So trying to actually communicate that need is really difficult when the people are struggling with the basics, and which is why our strategy has always been to kind of focus on the more educated population, universities, more people who have a certain level of understanding, but the wider population themselves, you can't really reach them with technology, and trying to kind of educate them on, you know, all the processes of how you can donate, where you can donate, and so on. It gets lost because they are a little bit too far removed from the kind of understanding that we require for them. And so it will be interesting to kind of learn from Aaron how they are able to kind of use their technology in their setting, because in Nigeria it's the demographic is really struggling.
Okay. I think we'll definitely share the contacts, but Aaron, if you have any information you can give us in the chat for all of us participants, it would be great. But I want to ask Dr. Mohammed a question. Dr. Mohammed, you know the Abuja Declaration, where African countries, we're supposed to at least put 15% of our fiscal budgets into health. And as for the latest knowledge I have, and I apologize if I'm wrong, just 2 countries in Africa were able to meet that threshold. That should be, I believe it's South Africa and Rwanda. And I want you to help us understand, we know the constraints we have with our GDPs in Africa. So we are open to the fact that even if probably we put the 15%, we may still not have enough, and we may still need to have some support from our donors. But you understand we have an issue of donor fatigue that is going on the continent. And for that reason, I have to wonder, what will be the balancing act? And the clarion call that I want you to work with, and I like to quote your founding director, John Kengasong, recently when he was named as the head of the new bureau at the State Department in the US. He said that the best way to prepare for the unknown is to invest in the known. And that means strengthening everything that we currently are using. And he mentioned HIV programs, he mentioned immunization, he mentioned infectious diseases, he mentioned maternal and child health. And Caroline quietly placed blood right there in the middle of all those things. So with that in mind, Dr. Mohammed, how do we bridge this and balance it? We don't have the 15%, the donors are tired, but lives are at stake. What can Africa CDC do to try and mitigate what is potentially, to me, just a crisis that is happening every single day on the continent?
Really, thank you so much, and I thank you for quoting the founding director of Africa CDC, Dr. John Nkengasong, where he said the best way to prepare for the unknown is to work with the known. Having said that, the new DG of Africa CDC, Dr. John Kaseya, we're working on what we call the new public health order for Africa. And this new public health order for Africa addresses 5 things. Lessons we have learned from COVID-19 outbreak, COVID-19 pandemic response. And after many iteration and working, we've come to understand that if we in Africa address these 5 issues, we can be able to move the continent forward and prepare for the next pandemic. This was put, the request for support was made at a series of events leading to the 77 United Nations General Assembly. 5, I said. The first one is having strong Africa public health institutions. Strong institutions. The reason why we would need strong Africa public health institution is that you talk about donor fatigue. Sometimes we do not have efficiency in the way this money comes to Africa. But if we have strong national public health institution, the donors, when the money comes to Africa, it will be used to address the pressing need, the need of the country, and therefore reduce inefficiency, reduce wastage, and other things that really leads to donor fatigue. It reduces verticalization and processes of funding the same thing using different funds. So this is very important, and also it allows these public health institution to be able to have memory, institutional memory, so that when the funding ends, it does not necessarily mean the gains of that intervention by donor ends. It means that the country should be able to carry on with that program. One of the things we learned, Caroline, during the response to COVID-19 pandemic, was that some countries in Africa, 90% of what is needed, health consumable, is imported from outside Africa. And when there was a breakdown of the worldwide logistic chain because of the lockdown, many of our countries went into serious crisis of availability of some of this. Africa CDC had to set up a system where we were working with Ethiopian Airlines and the government of Ethiopia, bringing in products and distributing them en masse to our member states to keep them going, to keep them. We cannot continue that. Therefore, one of the things we are pushing very hard is expanded manufacturing of vaccine, diagnostics, and therapeutics on the continent to safeguard us against this kind of problem in future pandemic. We need to invest in public health workforce and leadership programs. This is very key. And is the workforce in health that responds to pandemics, that respond to outbreaks. So this is key, and we need to do that. Now you talk about 15% the Abuja Declaration. I think as of the last count, I know of just one country that's meeting that target of 50% of their budget. How do we encourage our member states to put minimum of 15% into health? We are here talking about blood and blood products for the most vulnerable sex people of our continent, of our society. Women who are delivering, people with cancer, people with sickle cell. We need to be able to use evidence, to generate evidence, to encourage, not just talk to the ministers of health, but talk to the Minister of Finance on how to put in more money into health. Finally, we need respectful, action-oriented partnership. And this is what you're doing, Caroline. You are partners that Africa CDC needs to work with to put this kind of agenda on the front burner. And when we talk to our head of states, when we talk to our ministers of health, to the ministers of finance, we will say, we've just had an interesting webinar, interesting event where we had very clearly the need to invest in blood and blood products so that our women would not die from childbirth, our women would not die from lack of blood transfusion, our children will not die because they do not have access to blood as at the time they need. We need to put this at the highest level, push for it, advocate for it, and ensure that we are able to get some of this funding to increase the amount of money given for health and health services. Thank you.
Wow, I think Dr. Mohammed, I will record that and wait for your invite to come and speak at the AU delegation when you're doing this and help you to make that ask. It is why CoBA was set up. It is why we believe in partnerships. It is why we believe that by coming together, we will make a difference. And Erica, you've listened to Dr. Mohammed speak, and I loved when earlier he spoke about setting up of the Africa Medicine Agency, whose target is really to reduce the bottleneck of regulation. Dr. Mohammed, I can assure you, for every speaker on this panel, when they heard that, they smiled in their hearts, because that is a big burden and in a way an obstacle to bringing all this wonderful work. And before I just put my question to Erica, I want to thank you on behalf of Africa CDC for the setting up of the public health institutes, and you have spoken to it. As a public health person, I thought that was amazing, setting that up and getting them to work. And I realized last time in the session in Kigali, you dedicated a lot of time to strengthening the leadership of those public health institutes. And I believe even in Lusaka, when you'll meet from Monday, you're going to really strengthen that. And that is the way the continent should go forward. And if that becomes a way to attract some of the donor funds that at the moment we are missing, I think it will be beautiful. So Eric, I want to come to you, and now we'll just keep our answers a bit short so that I go around and get some perspectives from all of us before we take some Q&As and we close. I think about what you've been able to do on the continent, and I see a lot of partnerships. But I also know that with the experience you've had, you're able to speak to us about some of the gaps we may have in policies and even the guidelines. And today we have Dr. Mohammed that is speaking so passionately and in such an open way. And I think for me, Dr. Mohammed, when Africa CDC was set up, I saw the problems of Africa starting to be solved, because finally we set the priorities and now we tell people these are our priorities and we help. What could you speak to that, Erica, in terms of the strength of partnership? What would you share with all of us in terms of what could we ask from the Africa CDC today? Doc has been very kind to share what they're already working on. Do you see any spaces that could be strengthened, or do you have any insights to share from your experience? Over to you, Erica.
So thank you for this question, and I'm really, honored to be able to contribute to this important topic, which is, gaps. I think that, as I said before, the vision is given indeed by the policymakers, so by the CDC, by the WHO, policy framework 2020-2023. I think that is our vision where we need to go, and this actual action framework actually has listed all the gaps. If I may, and I need to be short, for sure, like the enforcement of the national policy with regards to blood collection, processing, and distribution, and these papers is really outlining them all. But if I could actually ask, really in a very humble manner to put some energies is into creation capacity for fractionation. So reinforce what is existing in Namibia and Rwanda, really empower the South African facility, which is, I would say, is one of the most advanced in Africa. And also, Dr. Mohammed, I think it would be a dramatic improvement to push for GMP certification, building regulatory capacity for fractionation. I think that would improve a dramatic, would bring, a dramatic improvement into the ability to have, blood supply being sustainable, so to fully leverage on every single drop which is donated. That is my ask. I hope it makes sense.
It does make sense, and Dr. Mohammed, I know you have had, but we will have further conversations to capture all the asks. I think, Erica, thanks for that. I want to ask Dr. Nathan some one or two questions, but before that, I think I had one last poll that I just wanted to see how much knowledge our audience and our panelists have. Maybe if we could have that poll. I think it was a question about how many patients can be saved from one single pint of blood. So if we had to optimize this 1 pint of blood, how many patients can we save? And I think somewhere in the conversations, one of our panelists actually gave the answer. So I'm hoping that we can have an 100% score. So, Dr. Nathan, I want you to combine a few thoughts because I've had very many discussions with you and I know you can help us. First is, I want you to just help us understand who are the stakeholders in the blood ecosystem? Who should be the people that should worry about blood? You know, are there some designated people? Help us understand who those people are. And then secondly, I want you to speak to Bukola because I know you are representing an entity that has a focus on sickle cell disease, and just elaborate or support some of the points that she put across to some of the technologies and innovations that currently are available, even as we wait for others to keep coming. And I know, Bukola, you must have been a happy girl when you saw the recent announcement from the NHS about the new gene therapy. So, Dr. Nathan, just please speak to that a bit. We know that blood is scarce, you know, who should be the people to come in to work on blood, the stakeholders, and what would you say to Bukola today representing the Sickle Cell Society?
Great. Again, thank you, and great to be in this panel. It's getting us to, very good ideas on how to tackle the issues of blood. And your question is very pertinent, but I want to turn it upside down and ask who should not be the stakeholder in matters blood. And then you begin to realize that all of us actually are stakeholders. If you can try and look for somebody who should not be a stakeholder, you will not find. So that means that all of us really have to be a stakeholder. And as you said earlier in the beginning, that you could actually walk out of your office and you get an accident and you need blood and you can go to the hospital. You'll find all the paracetamols and all the antibiotics and everything else, but you won't find blood. So blood becomes the missing link, yet it is supposed to be essential. It's supposed to be present. So we are all stakeholders in matters blood, whether you are working in the industry, whether you are a farmer, whether you are a shopkeeper, whether you are a fisherman. Bottom line is that we are all stakeholders. And in terms of the industry stakeholders or partners, but again, just to revisit what the government should do, government actually is one of the biggest stakeholders in matters health in any country. The WHO mandates the Ministry of Health to be the sole guiding responsible partner in matters health. And thereafter, they can actually call upon other people to come and support. So to look at it from a more technical point of view, the stakeholders that I can actually think of are first and foremost regulatory authorities, the Pharmacy and Poisons Board, for example, in Kenya, the people who regulate and put in place laws to govern blood transfusion and blood collection and all this. These actually are going to be a very, very big stakeholder in this arena. And why I said this is because as we get to more advanced, machines that can fractionate blood, that can separate blood from different blood components, then you end up with plasma, which is normally wasted in Africa because we don't have the fractionators. So again, we need to put legislation in place on how to govern those products that can actually be very useful and can save Africa tons of money. In fact, where I sit, I look at blood as one area where we can be self-sufficient in local manufacturing. Blood is an essential medicine. It is one area that we can say within 5 years, Africa is self-sufficient in blood. We locally process it. We get the platelets, the RBCs exchange, and everything else, and plasma, and we actually fractionate this blood. We can be self-sufficient in Africa in a very, very short time. The other stakeholders that I can think of would again be, patient groups again are very, very key in terms of advocating for adequate blood. We know politicians love to listen to patients, they're the voters. If you want to get anything done in Africa, go through a patient group. They're quite strong, quite powerful, and they're listened to a lot by politicians. So that again needs to be put on the forefront. They need to go out there. I like what Damu said about a lot of ignorance in matters blood. And I was seeing the NHS website on blood transfusion. It has so much information. Any question that you want asked actually can be answered by that website. So having this information going out to the public again would be very, very key. So again, for us, blood companies like Terumo, who have an interest in blood, again, are very, very major stakeholders. Those that do the diagnostics, checking for syphilis, HIV, again, are very, very big stakeholders. But overall, all of us are stakeholders, and we should take an active cue in matters blood because we could need it any minute, any time. So let us all participate in this blood mechanisms. Thank you.
Beautiful. And I think, Dr. Nathan, you are shy to mention Terumo actually do the red blood cell exchange, Bukola. So you want to speak to Dr. Nathan and check that the technology is available in Nigeria, and you discuss how it can become available so that we are able to move the patients from a sickler state to a trait state and see that they can be well. And Bukola, now I want to ask you a question, and in a way you can also make it a way of summarizing. I have seen the work that you've done, but I wonder, what do you see, what is the space for the patient bodies, whether it is the hemophilia bodies, whether it is the sickle cell bodies? You have decision makers sitting in this particular panel today. We have the Africa CDC. What do you think you can do to strengthen the voice that you're putting out to them? What call will you put to the people affected by the hemoglobinopathies there, to try and strengthen their voice? Not to say that the issue should be ignored in any way, but just how can you strengthen so that when you speak, you are heard? And I want you to talk to us a little bit about the patient organizations, even as you give a little bit of your closing remarks.
Thanks so much, Caroline. And I found what Dr. Nathan said interesting, that patients are listened to, because I don't know where he is, but patients are not listened to. Patients, I feel like, especially in the professional medical community and a lot of people who are living with chronic conditions that are having to constantly interact with the medical system, will tell you about the frustration of being a patient. Patients, it feels like even when they're designing policies or when they're designing interventions, patients are the last people to be thought about, right? It feels like you come up with a solution or what you think is a solution, right? And you roll it out. And when it doesn't work, then you say, oh, actually, maybe we should ask the patients what it is about it that isn't working. But if you had put them in the beginning, in the design phase, then we can actually have that actual collaborative process. So like Dr. Nathan said, the patient community is just as important as any of the other stakeholders within the healthcare space, not just the blood space, within the healthcare space as a whole, right? Because we're the ones living with whatever it is that you're trying to work on. And so giving patients that equal seat at the table is something that I find really interesting. And like you said, why I was really excited to speak here and to speak at CoBA is because I listen to a lot of like webinars and conversations on, it can be sickle cell disease, it can be blood management. There's never a patient on the panel. It's always just the professionals or the kind of bodies that are working on it, and they sit down and they have this conversation and they pat themselves on the back and everyone goes away and feels like they've done a good job. But if the patient isn't there in the room or on the table where you're making the decisions, then it oftentimes, I feel like it's usually lacking in the way that you're able to roll it out. So I really appreciate the opportunity to speak for patients on this particular panel. And when when we are sitting with like large organizations like the CDC, for us, it feels like those kinds of organizations are too far away, removed, right? Because most patients aren't interacting with those kinds of bodies, right? Who we're interacting with, like Dr. Mohammed said, is the healthcare workforce, right? The healthcare workforce are the people that we're facing, the nurses, the doctors, the lab scientists, and they're the ones that can either make or break the kind of care that we receive. And so much of what the interventions that the CDC and organizations like that have to do really has to be with that workforce, because they are the face of the healthcare system. And really, if there's any kind of call to action or ask that I would like, and like I know a lot of patients would be, is that investment in the healthcare workforce. Because even when there is no blood available, or even when there's no medicine available, the interaction that you have with the healthcare worker is really just as vital as the medicine, is just as vital as whatever intervention that they're going to give you. The availability of that healthcare worker is also just as important, right? Because so many times, as someone living with sickle cell, for example, if you go to a hospital, and there's no hematologist, or for example, there isn't somebody who actually understands what you're going through, that's going to be the difference between the type of healthcare that you receive versus if you go to a place and there is a healthcare worker that's knowledgeable on what it is that you actually come there for. So for me, that what I really want to see is that investment in the healthcare workspace. We all know what the challenges of the healthcare workforce is in a lot of African countries, and the kind of brain drain that's going on, the general kind of frustration and disinterest that we see with the healthcare workers. All those things are felt by the patients, right? If the nurse is unhappy, or if the doctor is unhappy with their work conditions, it's the patient that's going to feel it. And so for us, we really need to see that like prioritization of the healthcare workforce so that we can feel like there is an interest. And just to say that we actually use B Medical Systems transport boxes for our blood. So I was really excited to see you on the call as well. And it's just an example of what Dr. Mohammed said. When we wanted to start doing the logistics of blood, we had to import those boxes from Switzerland, no, Belgium, or Luxembourg. No, it came from Luxembourg. And for us, it's just like these things, they have to be available locally, right? If every time we need like a medical box, or if there's something that's wrong, we have to get those parts from Luxembourg, or we have to import those parts. We need to be able to have those things available locally, manufactured locally, so that the prices as well, because the price we bought it 2 or 3 years ago, because of the devaluation of the naira and the cost of the dollar, it's like tripled for us, right? So we need to be able to have those things available locally. So for me, that's what I would say is really the asks of the patient community. And thank you so much again for CoBA. You know, we really like to work in a space where we feel like the patient voice is just as important as the medical voice, as the international organization, because there aren't a lot of kind of collaborative spaces like that for us to be able to express ourselves. So I really appreciate you giving us this platform.
Wow. Bukola had run out of time, but since you're speaking for the patient, I just had to allow you. So Erica, I know you want to say something, just say. Then Aaron, you speak for the youth and you bring it home for us. And then I will hand it over to my colleague Samira before the time expires. So over to Erica and then to Aaron. Tell us about the youth.
I was just wanted to say to Bukola that I really agree and I understand the issue very well. It will be, you know, our way also to participate to CoBA and to work with you guys is to better understand which are your needs and try to come to a solution that suits everyone. We cannot disregard the voice of the patients, of course.
Wow. Thank you so much. You must be patient-centric at all times. Aaron, in 1 minute, your thoughts and what youth can do. And you can go beyond the 1 minute because I need to hand it over. You guys have been wonderful and amazing. Thank you so much.
Thank you, Caroline. I will try to stay within the 1 minute, but allow me to just say that my feelings and sentiments are similar to what Bukola said. It's the same way she feels about patients not being listened to. It's the same way I feel about innovators not being listened to and not being supported. So in order to achieve impact, it would be great, especially now that I know this call is holding or being presented by different heads of public institutions and government bodies. It would be good to get that kind of support from such institutions. Many a times we see public resources spent to build new solutions when those solutions have already been built by innovators. So it would be good to get that kind of support. But now, in terms of the youth, I think Africa itself has over 650 million youths with diverse skill sets and talents. We believe that this diversity could be the change that we need for solutions engineering. So youth need to be at the table, the solutions engineering table. For example, how can we use this diverse skill set to improve blood donation on the continent? How can we employ music, comedy, art, and so much more to champion increased blood donation? So it's just about technology. Youths are the leaders of tomorrow, but for that tomorrow to come, I think we need to be supported by the leaders of today. And this support can be given through mentorship, funding, moral support. And such support would allow innovations such as Damusasa not only to see the light of day, but also to be tested and qualified for use in solving our problems using our solutions. That way we could derive meaningful impact from the heavy investments that we make in educating our youth. And that is my final rallying call to the youth to come out and be part of the solution, not to be spectators. Thank you very much.
Excellent. And to take the cue from you, the parting and closing remarks will be done by our youth. Over to you, Samira. And I'm sorry we haven't had time for the Q&A. Samira, please, it is your turn as the youth. Bring it home for us.
So much, Caroline. I'll try and make it as short as possible. So a big thank you to you, Caroline, once again for the outstanding session moderation. And I want to thank our speakers for their enlightening contribution today and to all participants who stayed engaged until the end of the session. As we part ways, let's carry with us the important takeaway that this conversation should not end here. We should not conclude this conversation here. The topic of blood should resonate across every forum where it remains unspoken for. All in all, I will want to invite you all to our upcoming event. Feel free to register for them. The Coalition of Women's Health in Africa is hosting an official session for CPHIA event tomorrow on November 24th from 12 to 14 CAT. 13 to 15 EAT. Additionally, AHB will host an in-person event at International Conference of Public Health in Africa, emphasizing on the topic acceleration of universal health coverage through the private sector. This event will be held in Lusaka, Zambia, and at the Mulungush International Conference Center on November. Lastly, there will be the AHBS event scheduled to take place in Accra, Ghana on May 23rd, 2024, with a theme centered around a new dawn of partnerships for women's health. Lastly, I'll thank you all once again for attending the session, and we look forward to seeing you at the upcoming events. Thank you.
A special thank you to the Africa CDC, Dr. Mohamed Abdulaziz. Your insights were priceless. You shared with us. We feel inspired to a new Africa, having listened to what you've said. And I can't wait to engage with you and learn even more. Dr. Nathan, Erika, Aaron, Bukola, and to Dr. Nakul Reika, thank you so much and God bless you. Please give us feedback, guys, before you leave. Samira is gonna project a QR code. Let's hear what you thought of it and we'll answer your questions later on. Thank you, everyone, and God bless you all.
Thank you. Bye-bye.
Thank you.